Hello, everybody. It's my pleasure today to introduce Brad Haverkos. It's 3 minutes past the hour, so I'll go ahead and get started so that we can hear his presentation. So Brad is a accomplished T-cell lymphoma specialist here at the University of Colorado. He comes to us from a fellowship in Ohio State University, the Ohio State University. There he completed a master's degree in medical science. And he also has a master's of public health, so he's a double master. He has specialized in T-cell lymphoma since his fellowship, and upon coming to University of Colorado as faculty in 2015, led and co-directs a multidisciplinary cutaneous lymphoma clinic. He's a PI of multiple lymphoma-specific clinical trials, specifically interested in immunotherapy, and he also has a laboratory enterprise also focusing on this disease. So I know I speak for all our faculty when I say that we are very grateful to have Brad at this institution, managing these complex and very dangerous disorders. So Brad, take it away. Thank you.
Thanks so much, Dan. Go ahead and get started here. Thank you all for joining. This is just a brief overview of what we'll discuss today. I'll talk first some brief background information and then go over some cases, primary cutaneous T-cell lymphoma cases, discuss some of the management of those patients, and then go on to discuss some of the more aggressive nodal T-cell lymphomas, talking about both their initial treatment as well as relapsed. And then we'll spend the last few minutes discussing some of the new and exciting future directions in T-cell lymphoma. So as I'm sure this audience is aware, T-cell lymphomas are rare. They encompass about 10 to 15% of non-Hodgkin lymphomas. So there's about 80,000 cases of lymphoma each year in the US. So if you do some quick math, there's upwards of around 200 cases of T-cell lymphoma in Colorado each year in the US. So while rare, we certainly see them, and their burden of the disease is the burden of this disease is high, irrespective of the number of cases. They also, as this audience is probably well aware, they're a very complicated set of diseases, both to diagnose and treat. The diagnosis really requires sort of this integration of both the clinical presentation as well as some laboratory features, and certainly critical to this is the histologic sort of genophenotypic information that we get from our pathologists. And really involving a pathologist with some expertise in T-cell lymphoma is really important to make sure that we're coming up with the right diagnosis. If we don't have the right diagnosis, it makes it pretty challenging to come up with the right treatment plan for these folks. And historically, about 10 to 25% of cases were misclassified. I do think we're doing a bit better on this front, but there still are a number of T-cell lymphomas that are misclassified or not given the appropriate subtype in T-cell lymphoma, and certainly still see cases where the lymphoma is entirely misdiagnosed, and it's a T-cell lymphoma when it was called a classical Hodgkin lymphoma, etc. Multiple subtypes I mentioned, and makes it certainly complicated to figure out what the right approach for these patients is. There are a number of different systems to categorize T-cell lymphomas. We all probably know the basic breakdown of lymphomas, either classified as either non-Hodgkin lymphoma or Hodgkin lymphoma. And then based on the lymphoid cell that's affected, we classify them as a T or B cell or NK cell lymphoma. In the T-cell lymphoma space, we can think about things sometimes whether they are primary cutaneous diseases or systemic diseases. I don't love this classification, but it is a classification system that exists. And then within the systemic group, we sometimes will think about the disease, whether it's leukemic or extranodal, or to say nodal disease. And really what we're focusing on today are the nodal subtypes and the primary cutaneous subtypes. The historic nomenclature for this set of diseases of T-cell lymphomas was really either whether it's a cutaneous T-cell lymphoma or we call peripheral T-cell lymphoma, and this causes some confusion. And so one of the things that I find helpful, both to think about the diseases and to categorize them in my mind, and also figure out, I think it's a good way to tell patients about their disease, and also helps us figure out how we might approach them clinically and how we might treat them or manage them. So I find it most helpful to really classify these set of diseases as whether they are indolent diseases or aggressive diseases. And then it becomes much simpler to me. And I try to simplify things and lump things together as much as possible. So in the indolent basket of T-cell lymphomas, the vast majority of these are going to be your primary cutaneous T-cell lymphomas, most commonly mycosis fungoides. But notably, there are a number of nodal T-cell lymphomas that can present indolently. And when we talk about nodal T-cell lymphomas, these would, many people refer to these, and myself too, we'll call these PTCLs or peripheral T-cell lymphomas. Sorry for the alphabet soup there. Whereas the aggressive subtypes are, the vast majority of those are going to be your nodal T-cell lymphomas. And only a minority of aggressive T-cell lymphomas are primary cutaneous T-cell lymphomas. But it is important to recognize that there are some cutaneous T-cell lymphomas that are aggressive. You do die from them, or can die from them, and warrant aggressive treatment. So we'll first talk about indolent T-cell lymphomas, as I mentioned. Indolent T-cell lymphomas are really treated as a chronic disease. And this is a very similar paradigm to what we see in our other indolent B-cell lymphomas. In most of our indolent T-cell lymphomas, our cutaneous T-cell lymphomas, typically will present in early stage forms of the disease as what we call patch or plaque stage mycosis fungoides. And I'll show you some photos of that in a few slides. We tend to approach this disease with low intensity, non-curative treatments initially. Our most common treatment that we use for indolent CTCL or early stage CTCL is phototherapy, but there are other skin-directed therapies as well. Important to mention, though, that symptoms, even from these indolent diseases, can severely impact quality of life. They're not really, we don't think that these treatments are curative. So many people, and the majority of people, will relapse at some point in their life if they live long enough. And these indolent or early stage diseases can progress to more aggressive advanced stage diseases where we need more aggressive treatment. And certainly in that scenario is where we see people that can die from their disease. So first, I'm not going to go over every subtype or every type of treatment for T-cell lymphoma, either indolent or the aggressive variety. But to know that in indolent cutaneous T-cell lymphoma, we have both skin-directed options to treat them. Usually we use these in the early stage of the disease and when the disease is indolent. But then we also have a number of systemic treatments available to us that kind of span the whole gamut, and it's too much to really discuss in today. I'll do my best to go over some of these. So the clinical phases or phenotype of cutaneous T-cell lymphoma we're talking about mainly is mycosis fungoides. Really the studies that we'll go over are really applicable primarily to mycosis fungoides. And when we talk about early stage mycosis fungoides, we're really mainly saying patients are presenting with these patch or plaque stage disease. So this is the most common presentation, how we see individuals with these patches where you can't feel them, plaques where you can, if you close your eyes and rain your hand over it, you could feel the plaque on your hand. It'd be rough and scaly. There's some nice data from a big global retrospective effort that does show that even these early stage patients with plaque stage disease do a bit worse than patients with patch stage disease, but both are considered early stage disease. Whereas on the right side here, these patients with what we classify as a tumor, where it's more raised and round, or patients that are erythrodermic, red from head to toe, those are more advanced stage diseases and tend to have worse prognoses. So I alluded to this, how we treat indolent cutaneous T-cell lymphomas, mainly mycosis fungoides, treated as a chronic disease. We typically will approach individuals initially who only have skin involvement with skin-directed therapy in the form of phototherapy or narrowband UVB light. And this generally works okay and generally works to some efficacy, some amount of efficacy for people with early stage disease. And many people can go on for years, either continuing UVB light to maintain their disease, or in some instances never relapse but in most people who live long enough, their disease will relapse after some period of years. Then they go on to get other either oral therapies that we use or some of our more targeted IV therapies. Some individuals kind of stay in that bucket of just needing oral or targeted therapies, but some individuals go on to need more intense therapy. There's even a select few that may even need things like allogeneic bone marrow transplant, although it's increasingly uncommon that we need to do allogeneic transplant for these folks, but it remains an option. Fortunately and encouragingly, there's really a number of exciting experimental treatments. I'll talk about some of the exciting clinical trials at the end that are ongoing in T-cell lymphoma, and I think the future really is looking better for these patients. And so I mentioned that paradigm of initially approaching patients with light therapy or skin-directed therapy, and then moving up the ladder in some terms of intensity of their therapy. Some individuals, it's also important to note that this is really a stage-based treatment approach for cutaneous T-cell lymphoma, where early stage disease on the left side of the figure here, you're approaching them mainly with skin-directed therapies, although there's sometimes we need to add other systemic therapies to improve response. But then on the right side, and we talk about those patients with tumor stage disease or patients who are erythrodermic, again, red from head to toe, and certainly those with other lymph node involvement or organ involvement, we usually use a whole host of different systemic therapies. And so I'm going to try to kind of discuss why I might choose certain therapies with a number of illustrative cases here. So this is the first case of an individual with severely symptomatic folliculotropic mycosis fungoides. So you see in this figure, his on the left, his photo demonstrates pretty significant body surface area. We stage individuals with cutaneous T-cell lymphoma by this TNMB scoring system, where T is the amount of skin that's involved. And you get, when patients have more than 10% of their skin involved, that'd be T2. And then patients with T4 have more than 85% of their BSA involved. And then N for nodes, M for visceral disease, and B for blood involvement. So this individual was a stage 1B. And I bring up this case first because it's important. I suspect that many on the call are oncologists. And so it's important to remember that radiation has an important role in cutaneous T-cell lymphoma and is a very effective therapy. So we used to use the standard dose of 36 gray for individuals with cutaneous T-cell lymphoma to get total skin electron beam radiation. So this is total skin radiation by using the Stanford technique where you kind of do these little poses in the rad-onc suite so that they can unfold your skin and radiate every square inch of it. I mentioned we used to use this standard dose of 36 gray. It was a longer course, more intense, more radiation. But later we've sort of learned that we can use lower doses, which gives us the opportunity to be able to retreat individuals multiple times over their lifetime with total skin electron beam radiation. Important to note that this is not a curative therapy, but there's a very, very high response rate in most of our patients. And so one of the things that we've learned is that maybe we can follow total skin electron beam radiation by additional therapies that will prolong their response, remission, and improve their control of their disease for a longer period of time, and ultimately improving their quality of life. And I won't go through this entire slide, but you can reference this in the NCCN guidelines or elsewhere. The Olson paper that listed this staging parameters. But we have a TNMB scoring system, and based on that score, you get a stage, and then that helps us figure out what the best treatment path forward is. T for skin, N for lymph nodes, M for visceral involvement, and B for blood involvement. Based on that composite score, you get a stage 1 through 4. And so in these next couple cases, I'll also highlight the stage that each patient had to kind of remind you of the staging system. So this is a 50-year-old gentleman that had increasing plaques. So it had gone through a number of skin-directed therapies, some radiation, phototherapy, had gone on some systemic agents like retinoids and a subcutaneous injection of interferon and methotrexate orally. Didn't respond to those. Eventually, this individual went on to get a drug called brentuximab, which is an antibody drug conjugate targeting CD30. And just to recap, this patient would have been a T1 since they have less than 10% of their skin involvement. We classify that as a T1, and this is stage 1A. So even though this patient was a early stage disease patient, he unfortunately progressed on skin-directed therapy and eventually needed a number of systemic therapies. So I want to highlight the trial that led to brentuximab's approval in cutaneous T-cell lymphoma. This is based on the ALCANZA trial. This is a trial that randomized patients to either brentuximab or dealer's choice of methotrexate or bexarotene or targetin. Important to note the most critical inclusion criteria was that it required that patients had at least 10% CD30 expression in the neoplastic cells or in the tumor biopsy. And you'll see this again, this 10% expression is relevant in a later study that we'll discuss in the aggressive nodal T-cell lymphomas. And I'll get right to the punchline on this study in the interest of time and say that brentuximab was superior in all accounts. And for patients that have CD30 positive, defined as more than 10% expression of CD30 in the tumor biopsy, brentuximab was better than bexarotene or methotrexate. Higher response rates, about a year longer progression-free survival, and a quality of life measure called the Skindex, significantly better as well in patients that got brentuximab. So really better on all accounts, and thus it's been approved in the relapse setting for cutaneous T-cell lymphoma. Noteworthy, and this is something that we note with the use of brentuximab in other lymphoma subtypes, the neuropathy is cumulative. And we do know that the maximal response in cutaneous T-cell lymphoma seem to get to your maximum response by cycle 6. By cycle 4 is sort of when that neuropathy usually tends to start to build, sometimes later, but we usually don't see much neuropathy before then. So what we have done is we get to that maximum response, and then we think about what the path forward is, and the path forward may be, some way spacing out the doses of brentuximab to maintain their dose, but trying to minimize the risk of neuropathy. Or we could switch to a different agent to minimize that chance of cumulative neuropathy. And then it always remains an option to retreat with brentuximab in the future should the patient or when the patient recurs. So those are important things to kind of keep in mind about brentuximab. And we'll skip to another case. This is a case of an individual with what we'll call large cell transformation, and really emphasizes the important point that we need to always be biopsying patients, getting skin biopsies at recurrence to see if there's any evidence of large cell transformation. Also to look for certain biomarkers like CD30, like we just mentioned with brentuximab, because things can change over time. People obviously develop large cell transformation, or they can present with large cell transformation. And people that are CD30 negative at early stage disease may be CD30 positive at a later stage or a different stage in their disease. Important to note about large cell transformation is that it can be CD30 positive and can be aggressive. It is not always aggressive clinically, but in most cases it is. This individual went through a number of systemic therapies that you see here. And so I want to highlight some of the points that are relevant in managing tumor stage disease. Keep in mind, picture of that woman with the large raised round lesion. Those are tumors. This makes you a stage 2B. We think about stage 2B patients and how to manage them. And we think about how many tumors they might have on their skin, whether it's a limited, isolated tumor, whether it's multiple tumors. This is going to change how we're going to approach the patient, whether the patient has clinically aggressive disease or evidence of large cell transformation. Those are going to impact our choices of treatment, where patients with limited extent of tumor disease, we may be able to treat them with less intense therapies and have achieved good outcomes. Whereas patients with generalized or multiple tumors tend to do worse prognostically, and we need to do everything we can to get control of their disease ASAP, because these are the patients that have multiple tumors or with large cell transformation, clinically aggressive disease. Again, are the people that unfortunately can succumb to this disease and die if the disease is not controlled. So it's critically important that we really approach those patients with those poor prognostic features differently, or at least with closer supervision than we would the other patients. And these patients with aggressive disease are the ones that we definitely want to consider for allogeneic transplant, since they prognostically do worse, and there is potential cure in allogeneic transplant for these patients. The last cutaneous T-cell lymphoma case that I'll discuss is a case of Sézary syndrome. In this photo, you see a gentleman who is red everywhere, and this we call this erythrodermic, when you're red from head to toe, or have more than 85% of your BSA involved with CTCL. This individual was a 74-year-old, had multiple non-diagnostic skin biopsies. Important, and I highlight this point, that his CBC was normal differential, because it's very easy to look at a CBC and see absolute lymphocytosis and then think about Sézary syndrome or other leukemic diseases. But it's probably more important to keep in the back of your mind that people can have Sézary syndrome with a normal CBC, and the only way we would really be able to look and identify how many malignant cells are in circulation is with things like flow cytometry and molecular studies looking at T-cell gene arrangement to identify that clonal population. And it's very difficult for our dermatopathologists to make a diagnosis of Sézary syndrome via skin biopsies. That's why you see so many non-diagnostic biopsies. And so it's in many ways, it's easier to make a diagnosis if you're able to think about what your differential is and send flow cytometry and T-cell gene arrangement. And then you can go back and do a skin biopsy and look for that same clone in the skin. So when we have a diagnosis of Sézary syndrome, this gets classified as B2 involvement. And when they're erythrodermic, then you're classified as having T4 disease. That's a stage 4 disease. This individual had a number of milder therapies like photopheresis and interferon, because they technically had sort of lower burden of blood involvement for their Sézary syndrome, and then went on to get this drug called mogamulizumab, which is really a game changer for this population of patients with blood involvement. So quickly, management on these erythrodermic patients. I mentioned that patients with, similar to how we think about maybe patients with tumor stage disease, low tumor burden, or less tumors, maybe you can approach them more mildly with less intense therapies. Do the same thing with people with blood involvement. Patients with lower level of blood involvement, so B0B, where you just can pick up the clone, or B1, you can tend to approach them with more milder therapies. But B2, you really need to think about giving people the best treatment that we can, or the highest chance of response, as soon as possible. There are lots of other measures that we think about to help with sort of the pruritus that comes with this disease. They don't really work, but we certainly can try them. The way we improve the pruritus is treat the underlying disease. I mentioned this gentleman with Sézary syndrome got this drug mogamulizumab. I mentioned this has been a truly a lifesaver for many patients with Sézary syndrome, with very high response very high responses in that patient population. Quickly, this was a randomized study that randomized mogamulizumab, or MOGA, comparison to a drug called varinostat, HDAC inhibitor. Key exclusion criteria was that these patients with large cell transformation were not included in the study. So it's hard to extrapolate to that patient population since they were excluded. But in this study, we saw really fantastic results in patients with blood involvement. And I will summarize my take-home messages about MOGA is that it is generally, and this is also data driven, not just entirely my opinion, but generally minimal side effects. Even with long-term use, there doesn't seem to be cumulative toxicity of the drug. The side effects, though, are immune-mediated. So MOGA has some ADCC effect that is directly killing some of the malignant cells, but it is targeting CCR4, which is also on a portion of our T regulatory cells, and so it's depressing Tregs. So the side effects are immune-mediated, many of them very similar to what we see in checkpoint inhibitors or PD-1 inhibitors. It doesn't seem that the severity of these immune-mediated side effects or the frequency of them is nearly as much as you might expect with a checkpoint inhibitor, but just to note that these are immune-mediated side effects. The overall response rate was 28%, which doesn't sound that impressive, but they used a very strict criteria on how response was defined, which is very different than every other cutaneous T-cell lymphoma study. And if we pull out just the patients with blood involvement, significantly higher responses in that cohort of patients, with very quick responses in that patient population as well. The time to response in blood is a month, which is great for this patient population. But we do know that MOGA does not work as well as we'd like in lymph nodes or organ involvement, and could work better in the skin. And so an ongoing effort of ours and others is to figure out if there are combination regimens that might improve outcomes. So this is my slide that I've stolen from Dr. Sherbino and modified it and made it my own. And the title is sort of, can we develop a personalized approach to cutaneous T-cell lymphoma? And I think the answer is yes. We're certainly getting closer. And this is, my biased view of how I think about approaching patients with cutaneous T-cell lymphoma, where you see starting kind of on the upper right here with early stage or plaque disease that maybe is not responding as well to skin-directed therapy. Think about adding a drug like targaretin to it. For the patients that are erythrodermic or have low-level blood involvement, we really like photopheresis, potentially in combination with interferon. We are stuck using pegylated interferon since the non-pegylated version is now unavailable. But regardless, pegylated interferon seems to be as efficacious as the non-pegylated version, and it's once-a-week dosing, which is nice for patients. But patients with high blood involvement, we really want to tend to use MOGA as soon as we can in that patient population. It's certainly our best drug at clearing the blood compartment, and like I said, it's truly lifesaver in many of these patients. We are learning about a number of mutations that these CTCLs can carry, and that there may be targeted approaches like JAK inhibitors for the JAK2 mutated activated patients. Other things we think about, whether they're cytotoxic, and how that's going to approach if they have a CD8 positive phenotype or a gamma delta phenotype, that may change how we're going to approach these patients. And I mentioned some of these other things on the left-hand side about brentuximab for CD30 positive disease, and how we really think about, based on the number of tumors, the approach may differ slightly, and also whether they have aggressive large cell transformed disease or not. So I know it's a lot to soak in, but we really are better at treating these patients than we used to. And of course, I'm happy to help at any time. So now we will pivot and move to the nodal T-cell lymphomas or systemic T-cell lymphomas. And what we'll primarily focus on in this second portion here is the PTCL NOS subtype, or not otherwise specified, the angioimmunoblastic T-cell lymphoma subtype, and then the anaplastic large cell lymphomas, which come in sort of two varieties of ALK positive or ALK negative. Everything else in there is different and really approached a bit differently in terms of its treatment. So we're not going to talk about those. We're going to primarily focus on those three nodal subtypes. And so these are the main, and these three nodal subtypes really encompass about 60% of all aggressive nodal disease. So PTCL NOS, or not otherwise specified, is a, as it sort of says, a disease that's not otherwise specified, and as you may guess, has sort of wide ranging of clinical presentations and pathologic features. It's hard to say much more than that in terms of clinical presentation for that subtype. On the other hand, the nodal T-cell lymphomas with a follicular helper phenotype, so this is inclusive of the angioimmunoblastic T-cell lymphomas. They tend to have a very characteristic classic presentation of widespread lymphadenopathy. They present with rashes, they present with arthralgias, many systemic symptoms, often have hepatosplenomegaly. They often have autoimmune phenomenon, whether that's cold agglutinin disease or hemolytic anemia. There's really a great amount of sort of immune dysregulation that's ongoing in these patients that causes a lot of these issues. Patients will present with a lot of effusions as well. They often can have so about a third of these patients are also have EBV association to them, and they'll often present with EBV viremia. Sometimes can also have concomitant B-cell lymphomas that's driven by that EBV, by the presence of the EBV there in the lab without having sort of good T-cell surveillance in the tumor microenvironment. But these patients present very typical with all the, that constellation of symptoms. The anaplastic large cell lymphoma patients present kind of a bit more like the aggressive B-cell lymphomas that maybe you all more frequently see. They do come in two varieties of ALK positive or ALK negative. ALK positive is our most common subtype in the pediatric population and younger patients with a much lower median age than the ALK negatives and all other T-cell lymphomas. Have a very classic look under the microscope, and so I wanted to just highlight some of the differences between aggressive B-cell lymphomas and aggressive T-cell lymphomas. Since many are more familiar with aggressive B-cell lymphomas, it sometimes is helpful to throw up how they may differ. And really what you see in aggressive T-cell lymphomas is more advanced stage, more constitutional symptoms, more bone marrow involvement, and more extranodal sites of disease like skin. And my routine approach is to do bone marrow biopsies on all of my aggressive T-cell lymphoma patients. I know in the aggressive B-cell lymphoma space, we moved a little bit away from doing bone marrow biopsies, or at least don't do them quite as often. But in the T-cell lymphoma patients, I almost always do them because about a third of them will have involvement. And this is involvement even without having sort of overt abnormalities in your CBC. So I'm always surprised and happy that I did bone marrow biopsies on my patients, because I often find low level burden of disease. So how do we approach these aggressive nodal T-cell lymphomas? We approach them with multiple cycles, 6 cycles of anthracycline-based chemotherapy that we use one of these 4 regimens, CHOP, CHOP, EPOCH, or brentuximab CHP, and we'll talk about the latter regimen there in the next couple slides. We often will give these patients 6 cycles and often consolidate them with an autologous bone marrow transplant, which many people can respond to, but unfortunately most patients still relapse. So I have 2 cases of peripheral or aggressive nodal T-cell lymphomas, the first being a systemic anaplastic large cell lymphoma. Important to know to be sure that this is a systemic anaplastic large cell lymphoma and not be confused by its primary cutaneous anaplastic large cell counterpart that is treated that is treated very differently than the systemic variety. So do not treat your primary cutaneous T-cell lymphoma patients like this. But for systemic anaplastic large cell lymphoma patients, typically will present about the age of 60. This woman had bulky inguinal lymphadenopathy, so she was a stage 2, diagnosed with ALK negative anaplastic large cell lymphoma. And she had these two, we still look for these two chromosome rearrangements that historically have been prognostic. It's a little bit unclear in the era of brentuximab if they are still prognostic, but DUSP22 rearrangements tend to be more favorable. TP63 rearrangements, unfavorable. It's not a typo, it's TP63. And patients that have neither DUSP22 or TP63 rearrangements also tend to do poorly. So we still send those rearrangements or look for those. This individual had brentuximab plus CHP. It is notable that she was not consolidated with an auto transplant. So this woman had a low risk IPI score. So she had a good performance status, a normal LDH, no extranodal sites of disease, and was an early stage. So she's a low risk IPI, ALK negative ALCL. She got treated with 6 cycles of brentuximab plus CHP and was cured. So that's a good outcome. And this is really based on, I'll show you some of the Echelon 2 data and show you some of the updates from ASH. This Echelon 2 data was presented a couple years ago and published at The Lancet in 2018. This trial randomized patients with CD30 positive PTCL. So that's defined as 10 or more % expression of CD30 in the tumor biopsy. Patients were randomized to either get brentuximab CHP or CHOP. Notable that 70% of the patients on this trial had anaplastic large cell lymphoma. And so really, in the case before, I commented that the woman was not consolidated with an auto transplant. And I mentioned that her IPI score was low. And my rationale, in this trial, patients were allowed to go on to an auto transplant. But in this trial, patients that had a low risk IPI score generally did pretty well with just brentuximab CHP, where the median progression-free survival is not yet reached, but it sure seems like we are having pretty lengthy remissions 5+ years out for the vast majority of individuals with anaplastic large cell lymphoma. So this is just looking at ALCL patients. In the intermediate IPI score, the curves are not quite as separated, and maybe the outcomes don't seem quite as good. And so for this curve is composed of both ALK positive and ALK negative. If we were to separate those out, the ALK positives would do more favorable than the ALK negatives. And so for my ALK negative ALCLs with an intermediate or even a high risk IPI, we still definitely consider and think about the role of auto transplant for those patients, because there is room for improvement, and I will, and in a recent study, suggest that there is improvement in survival in patients that go on to get an auto transplant. So in this trial, I mentioned 70% of patients had anaplastic large cell lymphoma. It is a big question what to do with the other 2 main subtypes on this trial of PTCL NOS and AITLs. And in fact, if you look at the progression-free survival in the top 2 figures there, you don't see a whole lot of difference between CHOP and brentuximab CHP. And in fact, in the AITL cohort on the right, the patients that got CHOP did a bit better. Now, what to make of this as a subset analysis, it's a bit unclear, but it is far from certain to say that these patients that are the non-ALCL subtypes, we don't yet know if they're really how much better their outcomes are improved with brentuximab CHP versus CHOP. And so my summary takeaway on brentuximab plus CHP so is that brentuximab CHP in anaplastic large cell lymphoma is better than CHOP. We don't really know if it's better than CHOEP or EPOCH or brentuximab plus CHEP, which is a regimen that was published at ASH this year. But it is better than CHOP, and it is the standard for systemic ALCL outside of a clinical trial. We get about, if you look at all comers, about a 50% 5-year PFS. I mentioned this trial, or not trial, this retrospective look at auto consolidation for ALK negative and non-ALCL subtypes. So this excluded ALK positive patients, and suggests that there is an improved progression-free survival in ALK negative, ALCL, and non-ALCL subtypes. And for that reason, anybody that is intermediate or higher ALK negative ALCL, I favor an auto transplant. There's some other ongoing trials that are of note and encouraging in aggressive nodal T-cell lymphomas. This study published by Dr. Ruan looked at oral azacitidine plus CHOP and saw super high response rates of 75%. I'll give you the caveat that the vast majority of these patients, 17 of 20, were all follicular helper PTCLs. So it's hard to know if that applies to other subtypes. Nonetheless, the alliance, there's an ongoing alliance intergroup study that is randomizing patients to oral AZA plus CHOEP versus duvelisib plus CHOEP in CD30 negative aggressive nodal T-cell lymphomas. There's also an ongoing brentuximab plus CHP in patients with less than 10% CD30 expression. We do know that brentuximab can work even as a single agent with patients that have less than 10% expression, although they've been excluded from the clinical trials that led to their approval. And there's another ongoing trial with a PI3K inhibitor called tenalisib. And then we published a trial using a nivolumab plus dose-adjusted EPOCH. We're working on figuring out where to go from here with that approach. Another quick case, this is a nodal T-cell lymphoma with T follicular helper phenotype. So I mentioned that AITL fits into this category of these nodal T-cell lymphomas with TFH phenotype. This is a pretty classic presentation of a woman with splenomegaly and rash and arthralgias and a positive autoimmune workup, positive Coombs, hypergamoglobulinemia. She also had EBV viremia, detectable by quantitative PCR. She treated multiple courses of steroids without a really diagnosis, had a core biopsy as non-diagnosis. A core biopsy that was inconclusive and non-diagnostic. And then she had a repeat excisional biopsy and eventually had a diagnosis of AITL. And so this highlights lots of important points to keep in mind. Core biopsies, really tough to get a diagnosis in T-cell lymphoma. This is a pretty classic, unfortunate story of delayed diagnosis and pretty typical presentation for this subtype. This woman had stage 4 disease, elevated LDH, got dose-adjusted EPOCH, got into a CR. Unfortunately, though, she relapsed about 6 months after completing her induction chemo. She relapsed with kind of all the manifestations of HLH and some really meeting criteria for secondary HLH, and also had EBV viremia. She had a lymph node biopsy consistent with relapse and had ICE and an auto transplant in CR2. I mentioned our approach is really to try to consolidate them with auto in CR1, which is where the preponderance of the data lies, but there is some data to do it in CR2 for some patients from the T-cell project, which is a large global effort looking at outcomes. So this is a schema of how I approach nodal aggressive T-cell lymphomas with a really focus just on the 3 most common subtypes, the TFH phenotype, the NOSs, and the ALCLs. Of course, the first decision tree is whether this is a patient you're trying to approach with curative intent or not. And if it is curative intent and they have ALCL, the answer is brentuximab CHP outside of a trial. For all the others, it's a bit more murky, and I won't get into how I go about choosing, but there are a number of any anthracycline-based regimen in the NCCN guidelines is a reasonable choice. And we certainly think about consolidating patients with auto transplant after their induction regimen. If it is not a curative intent, we think about clinical trials or other combination regimens. Really, kind of moving into a exciting phase, I think, in T-cell lymphoma, where we're really identifying better prognostic and predictive biomarkers that not only help us prognosticate, but also help us predict response to therapies. The classic, example that I've shown today is really CD30, but TP63 and DUS22 and ALCL patients and ALK, even before that. This study by Iqbal et al. Really demonstrated that the patients with a GATA3 gene expression profile do significantly worse than those with TBX21. And so, the future for this aggressive nodal subtype of T-cell lymphomas is really, we're going to be able to try to pull out the high-risk patients and treat them, hopefully on novel clinical trials and strategic clinical trials that really get at the underlying underpinnings of the biology of their disease. When patients relapse with T-cell lymphoma, I think we're currently at a point now where we do really have, we are able to stratify or to think about and identify to identify their subtype, and that let that dictate then our treatment approach. And for example, you see in the angioimmunoblastic T-cell lymphoma subtype here in the second row, you see here that patients that had AITL in the pivotal trial that led to belinestat's approval really seemed to respond better and more favorably than in comparison to patients that got belinostat and had PTCL NOS or ALCL. And similarly, you see here that AITLs really don't seem to do quite as well with drugs like pralatrexate. And so I think it's not just a drawing a name out of a hat and going with that drug in the relapse setting because they're all approved in the relapse setting. I think we can be a bit more strategic and thoughtful about how we choose our approaches in the relapse setting. And outside the context of a trial, I really prefer epigenetic modification for some of these retrospective studies and the pivotal prospective study that showed maybe a bit better response with HDAC inhibition in the AITL population. And so some clinically important messages about aggressive systemic nodal T-cell lymphomas that I want to remind you all of before going to the final section here is that treatment, I think now in 2022, is both in the newly diagnosed setting and in the relapse setting, subtype and patient specific. I think the mutational profile to have NGS testing can be useful in the second line therapy to help choose second line therapy. And that there's a nice study from a couple years ago that does suggest that using novel therapies or novel agents, not traditional cytotoxic chemotherapy, may result in better outcomes than that novel therapies that result in better outcomes than using cytotoxic chemotherapies like GemOx, ICE, et cetera, in that second line space. So it's really important to think about the second line, third line approach to these patients, given that most of them will recur. I mentioned this a couple of times, how the AITL and the follicular Hupper phenotype patients often present in a very inflammatory state with autoimmune problems. And two final points is that PTCL or T-cell lymphomas with an FH phenotype, they can initially be indolent. This is sort of an under-recognized phenomenon. I think now that we have better tools to diagnose T-cell lymphoma, we're identifying this disease earlier on, where patients can have less symptomatics before they have this terrible fulminant presentation of things like HLH. And so it's important to keep that in mind, that they can have a little bit indolent presentation. Keep it in your differential. And in that HLH also is a common manifestation of very aggressive proliferative disease. So in the last couple minutes, we'll go over some novel approaches in relapsed T-cell lymphoma that I hope kind of end on a positive note about the future and some exciting developments moving forward. I'll first just mention this study because it's a study that we led here. and I think a really fascinating approach to treating T-cell lymphomas and really other EBV-associated lymphomas. I'm not going to get into the details here in for the sake of time, but to know that there's 2-drug combo, an HDAC inhibitor called the nanatinostat, which then makes the cells, the EBV active, so that it then can be susceptible to using drugs like ganciclovir to treat them. So it's a kind of, it's been sort of named this kick and kill approach for EBV-associated lymphomas. And one of the things that we saw was really some early encouraging outcomes in the aggressive T-cell lymphoma cohort. So the PTCL-NOSs and the AITLs, and we're not going to discuss, but the NK T-cell lymphoma patient population as well. And so, small numbers, but this is sort of what we get in the T-cell lymphoma space that gets us excited. So it's an important, encouraging approach that we look forward to continuing to develop here. This is just some swimmers plots, and you see really some really lengthy responses in some of the T-cell lymphoma and some of the T-cell lymphoma patients, as well as some of the other DLBCL subtypes. So it's not only applicable to T-cell lymphoma patients, but applicable to all EBV-associated lymphomas. And is sort of a really cool strategy that I find really interesting and exciting. Some other approaches. This duvelisib is currently listed, which is currently listed in the NCCN guidelines now, is a promising PI3K inhibitor for relapsed disease T-cell lymphoma. I think eventually we'll get FDA approval, but it is currently listed in the NCCN as an option. There's been several other additions to sort of the PI3 kinase approaches. One using duvelisib plus romidepsin with actually a really similar overall response rate. So it's a bit unclear if the romidepsin's adding anything. But one thing that was observed is a little bit less adverse events when romidepsin was added to the duvelisib, which is quite interesting. Then a study that we participated in here is using a different PI3K inhibitor called tenalisib with a slightly higher, but probably similar overall response rate, and is also a encouraging strategy. It's not FDA approved for any indication, so it's not listed in the NCCN guidelines, or else it probably would be. Duvelisib approved in indolent B-cell lymphomas, so it can be obtained off-label. So a couple of again, sort of ending on a more positive, exciting note that just shows you sort of the breadth of trials that are in development under investigation in relapsed T-cell lymphoma. This brentuximab bendamustine, I think, is something that in the CD30 positive relapsed T-cell lymphomas is something that can be utilized. We've used this a number of times, even outside the context of a clinical trial. Really high responses, I think around 70%, if I recall correctly, presented at ASH in the CD30 positive aggressive T-cell lymphomas. The Rami-Aza approach is also a pure epigenetic strategy. It's kind of an interesting one that's in ongoing development from the folks over in New York at Columbia. And duvelisib Rami mentioned this as well as a encouraging approach for patients. A couple more exciting options. I personally really interested in the potential combination with immunotherapy, and epigenetic modulation with immunotherapy really seems really interesting. And we have some preclinical data as well to think why that might be. Us and others also have preclinical data to suggest why that might be a really interesting approach. A few antibody-based strategies just to mention. This probably offends the CAR people in the room, but I lump in the CARs under the antibody-based approaches. There's lots of challenges around using antibodies or CARs to treat T-cell lymphomas since there aren't unique antigens really on the malignant cells, but nonetheless are lots of things in the pipeline there. And then some pathway inhibitors, a really cool study that was just published by Alison Moskowitz looking at JAK-STAT inhibition with ruxolitinib. And in this study, she showed that patients that had an activating JAK or STAT mutation or STAT3 expression by IHC, had really good overall response rates around 50%. And I think that's really the future of the field in aggressive T-cell lymphomas, is trying to be able to identify who's going to respond to what therapies and utilize them. And then these are 2 clinical trials that we are participating in, hopefully, or we are participating in the balometastat and hoping to open this decitabine plus tolinapant study, which I also find a really fascinating approach that is it's a mouthful. It's antagonist of inhibitor of apoptotic proteins, but also has some really, really neat immunogenic, it may induce immunogenic cell death in some really, really interesting ways that we hope to explore further in the future. So kind of, some exciting trials that are there as well on the epigenetic strategy front. And then of course, last but not least, immunotherapy angles, still studying PD-L1 antibody as a strategy. And then, of course, lots of people are excited about this CD47 blockade as well. And so my last slide before maybe a few minutes for questions, I will similar to kind of how we think about CTCL and able to approach them in a stage-based manner or based on different clinical or pathologic features. I think we're really close to being there also for aggressive T-cell lymphomas. And I won't go through all the details, but happy to, I think, send out my slides afterwards and answer any questions. So with that, I will stop. I think I'm right at the hour. I'm sorry I didn't leave more time for questions.
Thanks, Brad. That was excellent talk, excellent overview. I guess before we go into your questions, I was going to ask, I heard you mention cure at one point on one of the cases with a PTCL patient. That kind of surprised me at the time. Do you generally say these are incurable, or does it just depend on the subtype?
Yeah, it depends a bit on the subtype and the risks. There are sort of prognostic factors, whether that be IPI or some other cytogenetic prognostic factors. When we approach patients with anthracycline-based chemotherapy, the goal is really a curative goal, but depending on whether it's their IPI score, depending on cytogenetic or molecular features, the chance of cure could be 70% or it could be 10%. So it's really kind of spans the gamut there. But regardless of your subtype, there is still a small chance of cure with anthracycline-based chemotherapy. And so it's often an individualized discussion, weighing the risks and benefits of trying to cure the disease.
Great. So Ziri Wong in the chat asks a couple of questions. One, I was also wondering about too, the mogamulizumab mechanism of actions. I didn't quite understand. I wondered if you could expand on that. And Ziri asks, does it work well in lymph node and other solid organ involvement as well, or skin involvement?
Yeah, good questions. I think the first question about brentuximab, it can be effective in CD30 negative cutaneous T-cell lymphomas. There's reasons that it could respond or could work and still CD30 negative. It could be related to the heterogeneity of the tumor cells, where some express CD30 and some do not. We know that if you biopsy, do 5 biopsies, you're going to get some different CD30 expression in all those biopsies. So response could be part related to the heterogeneity of the tumor cells. It also could be sort of immunogenic, sort of affecting like M2 macrophages, or sort of different mechanisms by way it may impact the other cells in the microenvironment and induce a response. Or it could be kind of bystander effect as well, where it's just killing some of the cells that are near it. With regards to MOGA, MOGA doesn't really seem to work well in nodal disease. I think it has some to do with that it's a naked antibody, and I think it doesn't penetrate well into the nodes for some reason. It does work in skin. It doesn't work as well in skin as it does in the blood. It seems to really, the antibody seems to really traffic well and circulate well in the blood and really do a really good job of knocking out the blood compartment. But it does work in the skin, just so it takes a bit longer to get a response. The overall responses in skin are, around 30%, whereas in lymph nodes, the response is, in the 10% range. And then if you were to go one step further and say, does it, the small population of patients that have, say, organ involvement, like lung involvement or other places, it really doesn't work in those patients either. So it does seem that the antibody does seem to traffic better to certain sites than the other, with the blood being the best place that it clears.
How exactly does that antibody work?
Oh yeah, it targets CCR4. So CCR4 is on the many of our malignant mycosis fungoides cells. So it's directly, causing cell death directly inducing cell death of many of the CCR4 positive malignant cells. But it also, CCR4 is expressed on a number of Tregs, and so we think that the second mechanism by way it works is sort of an immunotherapeutic angle, where it's depressing some of those T regulatories that are contributing to a suppressive microenvironment.
Great, thanks, Brad, so much for your talk. Okay, there's one more question in the chat now from Parikshit. For patients with MF, what would you say is the goal of treatment? Unfortunately, a lot of patients have improvement of skin lesions, but have significantly dry skin and occasional itching that persist. Do we tell patients that it is expected and not considered failure of treatment, or do you consider that a failure of treatment?
Yeah, so some patients can have other skin conditions in addition to the mycosis fungoides. So in this example, it's possible that the mycosis fungoides has been treated and patients still have things like eczema or psoriasis. When we do see there's a bit higher incidence of other skin conditions. In the scenario where they don't have just underlying eczema that's causing the itching, and it truly is just the mycosis fungoides that is driving the itching, that's really a failure of treatment more than anything. I think that usually we'll find in those patients that still have significant itching, despite, quote, clearing their disease, if you were to look and do skin biopsies and look with, molecular techniques, you'll still find the clone in the skin that's driving the itch. And so I think that's really, depends on the context, it depends on the scenario. I always try to advocate in these kind of situations to do biopsies, skin biopsies, to make sure that we know what we're dealing with, whether this is a failure of treatment or maybe we should be treating, with other things like emollients or other maybe eczema-like treatments.
Great, Brad. Well, it's 6 past, so maybe we should wrap up. And thanks for your talk today. It was really educational. Thanks so much.
Yeah, thanks, Dan. Hopefully all enjoyed it.